All right, to all who are new here, welcome. Welcome to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or you can sign up for the email list to be notified of upcoming webinars. We are updating those schedules very frequently, so if you are checking our website, then check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You'll have 72 hours to complete the quiz and the evaluation. This email will come from customer care at gotowebinar.com. So please ensure that this is done in a timely order in order to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during this webinar, please submit the question and we will review the questions at the conclusion of the presentation. This can be done in the dashboard. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. There is a handout for today's talk available for download from the dashboard, and the recording will be available after the presentation through a link on our website. We finalized this topic and the date details with the BOC on May 22nd. And on May 25th, George Floyd was murdered, and we have had nationwide protests on police brutality and civil injustices. We are proud to use Releve Sports Medicine's educational platform to share this important information. We hope that this information gives you a framework to start meaningful conversations in your local community. Our speaker today is Dr. Cleo Stafford from Emory University, who's an assistant professor of orthopedics and physical medicine and rehabilitation, who completed his sports medicine fellowship at Anterior Sports Medicine in Birmingham. So I'm going to have him take it away.
All right. So good afternoon, everyone. As Dr. Amy said, I'm Cleo Stafford, physiatrist and sports medicine trained, currently working at Emory in one of the team positions for Morehouse Athletics. And today I'll be speaking to everyone about do health disparities exist in musculoskeletal care. So I have a particular interest in this as being a person of color, but also in my current workplace. In my current workplace, we are a safety net hospital, meaning that we take care of individuals regardless of their insurance status and regardless of their income level, which is very important to me going into medicine because growing up, I saw a lot of individuals who are not able to seek care because of various circumstances. So without further ado, we'll go forward. So I have no conflicts of interest and no financial disclosures. So first, we'll just start off with the definition of health disparities as given to us by CDC. Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimum health that are experienced by socially disadvantaged populations. They then go on to define those populations, and the risk factors are there at the bottom. The risk factors that you will likely hear me touch on today is inadequate access to healthcare and poverty. And poverty can present itself in various aspects, and I will highlight those throughout the talking points I have today. So essentially, I'll be using various research articles to highlight points in disparity of care to hopefully spark conversations around the country and around the world, and also we can improve healthcare for folks from all walks of life. So first, we'll start with fracture care. I work at a level 1 hospital, so a lot of my orthopedic partners are traumatologists, and they will send folks to me after they had their fracture for various other ailments as well that land to the realm of sports medicine. Nevertheless, it's something I'm still interested in as well. So the first study was done by the neurosurgery department at the University of Florida. It is entitled Race and Socioeconomic Disparity in the Treatment and Outcome of Traumatic Cervical Spinal Cord Injury with Fracture. This is a retrospective study using a national inpatient sample database. This was done between the years of 1998 and 2009 when they took that data. To start off, The good news is that overall, you had improved outcomes of following traumatic cervical spine injury patients. I had an opportunity as being a physiatrist in training to work with a lot of individuals who've had cervical spine injuries. And those individuals not only sometimes lose the ability to use their legs, but sometimes, depending on what level of their cervical spine injury they have, they can use the ability to use their hands, which is very important, as we all know, that goes to doing everyday activities. So trying to improve their outcomes is very important. They did notice within collecting the data that surgical intervention did show an improvement in discharge outcomes and lower in-hospital mortality. Okay, why is the discharge outcomes very important? Well, for a cervical spinal injury patient, that's going to really set them up going long-term to deal with their new framework of life. And so whether it's going to acute rehab or going home, we want to make sure that they have the best possibility as we can. What they also noticed within the study is that African Americans and individuals in lower socioeconomic class, for one, had increased odds of worse outcomes, and two, had decreased odds undergoing surgical intervention. The reason why I brought up that second bullet point is because you see, for those who did receive surgical intervention, they had improvement in their outcomes. However, I will note that for a lot of the folks, a lot of the African Americans, individuals lower socioeconomic class, a lot of their fractures were ballistic, meaning that they came from a bullet. And a lot of times when you have a ballistic fracture, the surgeon doesn't always go in there for surgical intervention because by going out and taking out the bullet, you could increase the risk of infection, which could explain why some of these individuals did not receive surgical intervention, but it will not explain why the vast majority of them did not. Now, next topic, race and gender influence the management of humerus sap fractures. This was done as a retrospective study using the National Trauma Database from 2007-2012. And the authors really want to know if race, sex, and socioeconomic status played a role in the surgical management patterns of these patients. They noticed that white males, among any other group in the study, received surgical management. Okay, there was no difference between white women and black women. And once again, white males compared to black males did receive surgical intervention. Now, the one big knock I have with the study is that we don't know that surgical intervention influenced their outcomes for better or for worse, but we do see a disparity in the treatment patterns. Next study shows Medicaid payer status is linked to increased rates of complications after the treatment of proximal humerus fractures. This was done by the orthopedic department in Wayne State in Michigan. This is a retrospective study looking at the National Inpatient Sample Database from 2002 to 2012. They compared Medicaid patients to private health insurance patients. Good thing they did in this study was that they matched the patients based on their race, age, and medical comorbidities in order not to skew the data. The primary outcomes of the study included what type of surgeries these individuals received, if they had post-surgical complications, and also their hospital stay as well. They did notice that there was a difference in the type of surgical intervention noted between the Medicaid and private health insurance patients. They noticed that individuals with private health insurance received surgical procedures that salvaged the humerus in the humeral head, as opposed to Medicaid patients who were more likely, and this was shown to be statistically significant, to receive more of a total shoulder replacement as opposed to these salvage procedures. Secondly, they noted that Medicaid patients had a 35% longer hospital stay. And lastly, Medicaid patients had an increased chance of having post-surgical complications, which include wound issues, infection, or respiratory distress, which would then coincide with them having a longer hospital stay overall. Sorry if you guys hear what's going on outside. Today I'm presenting from home, and sounds like my neighbor Shao is having a little bit of a meltdown, but I think he'll get past it soon, so sorry about that. So next is joint replacement. So I see a lot of individuals prior to them getting their joint replacement, whether it's their hip or their knees, and we sit down, we discuss all the non-surgical treatment options. However, sometimes they end up landing within the surgical care realm. And so this next study was done in New York, and it's entitled Disparities in Total Hip Arthroplasty Outcomes, Census Tract Data Showing Interaction Between Race and Community Deprivation. Once again, another retrospective study done using a total hip arthroplasty database between the years of 2007 and 2011. They compared patients who were in a low socioeconomic neighborhoods compared to patients in high socioeconomic neighborhoods. The primary outcomes were preoperative and postoperative pain and functional scores. The good news is that for the majority of the patients in this study, or in this case all, had improvements in their pain and functional scores. Black and white patients who were in high socioeconomic neighborhoods had similar pain and functional scores pre and post surgical intervention. The other good news is that there was no statistical significance between whites in high socioeconomic neighborhoods and those in low socioeconomic neighborhoods, which is a good thing. So it looks like compared in this study was that regardless of your income, it seems like you are going to have a good outcome, and your outcomes are going to be similar, which as physicians and medical care providers will we strive to have. However, we did see a statistical significant difference between Blacks in high socioeconomic neighborhoods and those compared to those in lower socioeconomic neighborhoods. And so those are the type of things when I see as physicians, how do we counteract that? How do we decrease that disparity so we ensure that all individuals, when they receive treatment, are given the best possible chance for a great outcome? Next study is racial and ethnic and socioeconomic disparities in total knee arthroplasty in 30 to 9-day readmissions. There's another retrospective study of the inpatient discharge records from rather large states, California, Florida, New York, and Maryland between the years 2007 and 2014. That included patients that had private health insurance, Medicare, Medicaid, and various income levels. And their primary outcome was readmission rates. And typically, if you're going to have a readmission rate after somebody that has a knee replacement, you've had some type of complication that needs to be treated in an acute manner. They noticed that Black patients, regardless of their insurance, had a higher readmission rates compared to their white counterparts, which is not a good thing. Then, once again, they noticed that Black patients, regardless of their income, had higher readmission rates compared to their white counterparts, which is different than the previous study I showed. So this one's showing it didn't matter their insurance, it didn't matter their income, they're at a higher risk for having to come back to the hospital and be admitted for a total knee replacement. Overall, they noticed that individuals with Medicare, Medicaid, and lower income levels are at higher risk for readmission. So moving right along to a population that I believe most individuals on this webinar today are probably associated with. The first study that we have up is a pretty cool one. So it's entitled School and Community Socioeconomic Status and Access to Athletic Training Services in Wisconsin Secondary Schools. So essentially the researchers here sent out a survey to over 400 schools in the Wisconsin area. They had an over 80% response rate and they sent it to the athletic directors. Highlights of the study: higher schools that had a higher percentage of students who qualify for free lunch, they were less likely to have an athletic trainer on site. Schools that landed in the lower than medium household income were less likely to have athletic trainer on site, which makes sense. If you're in a lower household income area, you're more likely to have students that qualify for free lunch, all right? But now let's analyze the data a little bit more. So if you're in the lower third of students that qualify for free lunch, one can theoretically say that you're going to probably be in a higher socioeconomic area. Or you're likely to have, based on this study in Wisconsin, to have your athletic trainer there on site 17 hours per week. And during that time, you're taking care of roughly 18 athletes. All right. Now let's go to the other end of the bell curve. If you're in the upper third of a school of students that qualify for free lunch, you're likely to have an athletic trainer there around 10 hours per week, which is a 7-hour difference than those who are more in an affluent neighborhood. But here's the kicker. When the athletic trainer is only there for 10 hours per week, they're responsible for roughly 10 more athletes, which one could theoretically highlight there a reduced access to care, because you could imagine, I know a lot of athletic trainers here on this webinar, you're only going to be there 7 hours less per week compared to some of your other counterparts. However, you're responsible for so many more athletes. And it's highly improbable that a person can really get through all those athletes at that one setting. But once again, as we go down to look at median household income, if your school lies in a district that was in a lower third of the median household income, then your athletic trainer was there roughly less than 10 hours per week. And then you're responsible for close to almost 30 student athletes, 29. However, in a more higher affluent neighborhood, in the upper third of median household income, then you're likely to be there at least 17 hours per week. However, you're taking care of 10 less athletes. So the access to care there is far better. Well, why am I making the big statement about the access to care? There are studies that show that when you have medical professionals on site, then the individual is likely to get a diagnosis done much earlier than when they're not there. And we're relying on individuals that their expertise is not with the medical realm. And so that's very important when it comes to covering various high school sports, such as football, baseball, basketball, all these things. We all should strive to have a medical personnel, particularly in the sports realm, there on site to be able to handle these situations. So now let's go to the next paper, which is entitled Access to Care for the Adolescent ACL Patient with Medicaid versus Private Insurance. And this was done in the greater Cincinnati area. The researchers in this study did something that's pretty straightforward and pretty neat. So they contacted orthopedic offices in the area, 42 of them, and they gave a scenario of an adolescent patient that had a suspected ACL injury. And the first time they said they had Medicaid. Out of those 42 offices, only 6 of them accepted Medicaid. The next question that if they actually did accept Medicaid patients was, are you able to get this individual in within 14 days? Out of those 6, only 4. And so 4 out of 42 of those offices were able to get an ACL injury patient with Medicaid within 14 days. As compared to the private insurance patients, all of them accepted them. And 38 out of the 42 were able to get them in within within a 14-day time frame. Why is that important? There is enough data out there to suggest that when you have an athlete with an ACL injury that is not treated earlier, they're at a higher risk for having cartilage defects and also irreparable meniscus. Okay? If they have these high cartilage defects and irreparable meniscus, we're not only jeopardizing their return to play as an athlete, but we're talking about long-term sequelae. And these are the type of individuals sometimes I see at 25, 26 years old with advanced osteoarthritis for injuries they suffered as an adolescent playing in various sports. The next paper here was done by researchers at Children's Hospital of Philadelphia. It's a retrospective study entitled How Do Race and Insurance Status Affect the Care of Pediatric ACL Injuries? All the athletes in this study were 21 years and less in age, and they chose the 20 years between 2009 and 2016. Things I would like to point out, okay? We already talked about the access to care in the first 2. Well, Black and Latino folks were able to get to the operating room after an injury at roughly around 3 months, as opposed to Caucasian and Asian counterparts, they're able to get to the operating room in less than 3 months. But here's a bigger story. We look at public versus private insurance patients. Public insurance patients, they're almost double, they're not quite double, but almost double the time between getting to the operating room compared to the private insurance counterparts. And that's something that I definitely want to bring up, because what I just spoke to you about was the longer the time between getting to the operating room from the time of your injury, and let's say the athlete continues to play, they're at higher risk for having these concomitant injuries, which goes along with the next point. So when we look at the meniscectomy rate between Latinos and African Americans compared to the Caucasian and Asian counterparts, we see a statistical significance, because the Black and Latino patients, 43% of them had a meniscectomy. Now, why do they have a meniscectomy? Well, they have a meniscus that cannot be repaired. Then sometimes the next option is to take that piece of the meniscus that is injured. Why is that important? There's data to suggest that when a person has a meniscectomy, they're at a higher likelihood to have arthritis early on in their life than folks who do not have a meniscectomy. Granted, some of this data is from degenerative meniscus tears, but if we take it from a biomechanical perspective, as the majority of this of us in this webinar knows, the meniscus is a shock absorber. You remove a piece of that shock absorber, that means you're having more contact of chondral areas that should not be having those areas, doing high impact activities, which can lead to a higher degree of chondral injury. The next thing I want to point out is the clearance for sports. So for Black and Latino patients, only 56% of them received a surgical clearance to return back to sport compared to the white and Asian athletes, which was statistically significant. We go over to the public versus private insurance side. Once again, we see a statistical significance where only 50% of the public insurance patients receive clearance compared to close to 74% to the private insurance patients, right? Now, could some of that be related to the follow-up of these patients? Absolutely. If the patients are not able to make their appointment because of various reasons, mom and dad has to go to work, or the kids have to go to school, and they're not able to take out the amount of time to be able to get to these appointments because of various reasons, then a surgeon or someone else may not be as apt to release the patient because they feel like they may not be able to make it back safely. But the next thing that I did want to point out was that the time to clearance to sports, which was not statistically significant. So if they're able to get cleared, they're around not too far away from each other in the amount of time it takes them to get back, which kind of lets us know that, hey, it has something to do more with access to care and some other socioeconomic factors than sometimes the actual will of our patients that we're treating. Now, what could be some other possible reasons why these athletes are not able to return back to play? Another part of the study was that they looked at the number of physical therapy appointments that these athletes receive after having their ACL reconstruction. One of the biggest things we see is that the number of sessions that these athletes receive. So the Black and Latino patients in this study receive roughly about 9 less physical therapy appointments compared to their Caucasian and Asian counterparts. And then when you look at compared to public to private insurance patients, we see that they're roughly getting around 10 less physical therapy appointments. And so they don't fully go into the reason why they're receiving this less appointments, but I would say that will definitely affect their outcome, whether it's range of motion, which is standing there, and also their quadricep strength, which is another, as a lot of us know, is very important for getting the athlete back to competition. All right, to round this out here, this study is entitled Socioeconomic Status Impacts Outcomes Following Pediatric ACL Reconstruction. This was done by researchers at Children's Hospital in LA. It's another retrospective review done between the years of 2009 and 2015. All the athletes in this study were 21 years and younger. First thing they started with the study was that they point out the difference in household income between commercial and government/public insurance patients. So we're already highlighting disparity in the amount of resources these individuals might have available to them. Second thing is that they point out the amount of injury to their first orthopedic appointment. So we see for the commercial/private insurance patients, they're getting to the orthopedist in around less than 2 months, as opposed to the government insurance patients, they're getting to the orthopedic surgeon greater than 3 months, which once again highlights the opportunity for them to have these associated meniscus and other high conjugal injuries, and also highlighting access to care as well. The same thing can be said about the number of days from injury to MRI, less than 2 months here, close to almost 3 months there. Then we can also highlight once again the time from injury to surgery, which makes sense because if it takes them a while to get to the surgeon, it takes them a while to get an MRI, then it's going to make sense for them to take them a while to be able to get their surgery. So here they're hovering around 3 months, 90 days. And here we're almost close to double that time to which they can get to their surgery. However, the next thing I want to highlight is the amount of injury to the amount of days it takes them to get back to play, okay? Which is around 11 months, 336 days versus 13 months for the government insurance patients. But if you look at the last category, which from the amount of time from surgery to return to play, it's not a big difference, which explains that, hey, a lot of times it's not for the effort of athletes, okay? It's the access to care issue. And in this case, it seems like based on their insurance, based on this study. Now, the last thing this paper pointed out is possible complications when compared to commercial insurance patients versus government insurance patients. And that the government insurance patients had a 22% chance of having decreased range of motion. Now, if we think back to the study that I just presented to you from the Children's Hospital of Philadelphia, the individuals that have public or government insurance are more likely to have 10 less physical therapy appointments, which could affect that. On the next line, when it comes to graft failure, we don't see a big difference, which we don't want to see a graft failure, but at least we don't see a huge difference. The last thing here is infection, though. For the commercial patients, they only have 0% of them had an infection compared to the government insured patients had 4% with regards to infection. And so what I wanted to point out here in the various studies here is that the disparities are there. It's the multifactorial reason why they're there. However, we need to be able to recognize them and then come into plans to battle it systemically. Now, here are my references, and the reason why I do my talk is for my son here, Jackson, and in this picture here is about, he's a year old. He already knows how to take selfies, so I know my phone is going to be filled with these. But I want to make sure that my work is going to allow him and his colleagues and all around children and athletes and individuals around the world will have a better place than the one we currently have. And that is the end of my talk, and I will open it up for questions.
Awesome. Well, thank you so much. And so we are starting to get some questions coming in here. And I'm going to, I'll start this off. We have a question coming in from Karen asking about the Wisconsin study, which is about the access to athletic trainers, to see if this study has been done in other states.
Excellent question. I have not seen the literature on it, and I myself has thought about here, so currently in Georgia, thinking about redoing a study to see if we're seeing similar patterns around the nation. So I think it'll be an excellent project, not just based on states, but regionally, and also take it to the national level as well. I think that would be a great study to see because, once again, it will be highlighting access of care.
Perfect. Now, okay, I have another question about Medicaid and seeing that, yes, the studies are showing that difficulty in getting Medicaid patients to physicians. What has been your take in the Atlanta area in terms of Medicaid having access to orthopedics and sports medicine physicians?
I think some of the patterns are similar, and grateful for me, I work in a university at a level at a safety net hospital. So in my case, it's not as big as a deal. We take for all type of insurance. So in my practice, it's not as big a difference. However, for some of my colleagues who might be in private practice, it is a big deal. And I think it's less because they want to treat Medicaid patients, but the reimbursement. And as my colleague here, Dr. Henny's in private practice, it's not about just being paid for the patient. You have to pay for your staff. You have to pay for your office. And currently, the Medicaid reimbursement for such as injuries at ACL, sometimes in some folks' mind, when they look at the numbers, is not truly feasible. It's a shame that individuals have to think that way, but they also have to think about the economics. And I think that's the reason why you have a lot of the private practices are not willing or not able to take on as many Medicaid patients.
Yeah. We fortunately we do take Medicaid, so we end up seeing a lot of kids in our area. But yeah, absolutely, that's definitely the finances go hand in hand with that. All right, we had Jessica says, excellent presentation. So glad we're discussing and starting to address this as a priority in terms of disparities, especially in care and prevention. From Ronald, these statistics definitely are in line with observations I have seen in my 20+ years as an athletic trainer. I don't have a question, but this data does further strengthen the argument of the need for athletic trainers in all schools, regardless of economic status. The kids at the low socioeconomic status schools need access to athletic trainers to make up these gaps.
I agree with Ronald. You said Ronald made that comment. I agree wholeheartedly, absolutely. Athletic trainers are definitely needed, not only on the field, but also in the office settings as well. I think the skill set that you all have the opportunity to craft is definitely needed for not only just for athletes, for musculoskeletal care in general. And just unfortunately here in Georgia, in one of the counties where some of the schools had not had an athletic trainer, they've had 2 heat-associated fatalities, which I firmly believe that if we had a trained medical professional such as an athletic trainer, there will be it'll be less likely for an event like that to occur.
Yeah, great point, great point. Okay, do you think, this question comes from Hannah, do you think there are any concerns in clinician bias and level of care?
Yes, I think everyone has biases. I think that there's a chance that when someone from a low socioeconomic class They might have the various biases such as, well, they're not going to do well because they're not going to show up for the follow-up appointment, or well, they're not going to do well because they're not going to be adherent to the plan. So I definitely think biases in there. Some of the papers that I pointed out about surgical management patterns, kind of express that maybe there might be some biases in it. Do I think that all physicians think that way? No, I don't. But I still think that subconsciously sometimes it can definitely play a role in the treatment plan. Do not president of pushing opinion as well.
Okay, from Michael, he says, I used to live in Atlanta. Rural area schools have had a tougher time having an athletic trainer on site because of no money. Has the state improved in providing athletic trainers to these schools, or more hospitals gotten involved?
So great point. So being part of Emory Sports Medicine, we work with a group that deploys athletic trainers all around the greater Atlanta area. The area that I work in is the south side part of Atlanta, and luckily we've had the opportunities to have athletic trainers down that area. I think it definitely made a difference. I think at the state level, that's something that we can need to continue to work on. I think it's really been more at the county level, but it's something that definitely needs to be addressed. Not only from the data I've shown, but anecdotally, I think most of us, almost all of us, agree that having someone there would definitely make a difference. But it takes more than presentations like mine. It takes policymakers, and it takes us being advocates on every aspect, position level athletic trainer, and also at the school level to be able to make these type of differences.
All right, Olivia asks, as healthcare professionals, how can we be better advocates for our patients and athletes from lower socioeconomic backgrounds to receive expedient and quality care?
That is an excellent question. It is something that's going to take some time for us to be able to get to, because unfortunately the way healthcare is currently constructed, that doesn't allow for that. And so we have to come up with creative ideas to be able to do so. I know I saw an article out in California where they were encouraging physicians to take patients with their version of Medicaid, and they were doing so by doing loan reimbursement. That could be a possible way to incentivize folks to be able to want to get these folks in sooner. Another way could be a redeployment of resources. And so if we're taking resources from an area that may not be able to be as useful and apply it to our athletes, particularly in the school system. I think we all seen enough studies that show that athletes that are active, they go on to live healthier lives. And so I think that is one way in order to encourage our policymakers on to be able to do so. At a more personal level, getting involved in your membership societies, and when your membership societies craft statements to fight to be at the table to make sure that we are addressing these issues, as opposed to having a great talk about it and going back to our everyday activities, but having action plans afterwards.
Yeah. And just to add one more thing to that, on the ground level, as the athletic trainer, you can serve as an advocate for your patient. If you're there and you have a kid who's gotten hurt and you're having difficulties getting them in with someone, you have those relationships. You've been developing those relationships with your local physicians. You can, hypothetically, even I have people who reach out to me directly. Hey, can you get this person in? Absolutely. You develop that, and then from there, I know I had a kid come in with a fracture. It was a long bone shaft fracture that should have, maybe it should have been managed differently from the hospital setting, but regardless, because I have relationships with some of the other local folks, I was able to get them managed appropriately, and having that team and having that advocacy where standing up for your athlete, that could be another way that you can start right away. Okay, we have Karen is asking about, did any of the studies look at transportation availability?
I did not see that. I think that's the interesting point, but within the studies, I did not see it. But I think there are some other data to show that if the individuals we have Medicaid, at least within Atlanta, use Government transportation, which definitely plays a role. So sometimes I have patients that have 8 o'clock appointments, but unfortunately don't get there until 8:40 because of the transportation issue. That's actually provided by the county. So I think some of these studies, particularly when we're looking at these disparities, we have to look at some of the socioeconomic factors that are causing it. Instead of just saying there are factors, really deep dive and figure out why they're having factors. So I think that's an excellent point you just brought up.
Now, this question is coming from Amanda. Have you noticed a difference in the athletes under your care at the university level based on their socioeconomic status in their youth? For example, pre-existing injuries, injury rates, etc.
Say the question one more time. I want to make sure that I understand it.
Yeah, so the question being, so you seeing them at the university level, have you noticed any differences in those athletes based on, because hypothetically, and I'm gonna go kind of expand on this, hypothetically, we're suspecting that once they've gotten to the collegiate level, there's a lot more medical care that's based around them. There's a lot better secondary claim insurances that'll cover things that primary insurances won't. However, they may have underlying injuries or injury rates that are different based on their socioeconomic status in their youth prior to college.
So I think hypothetically, absolutely, I think that could be an issue. I haven't seen it personally, but sometimes I will have, at least at the university level, I will see athletes that have needs that, quite frankly, don't look like a 20-year-old's need. And then it makes me wonder how it got to that point. And so those little things like that, I question in the back of my mind. At the time, I'm just worried about how I can get my athlete, keep them getting active or get the best quality of life even after they're done competing sports. But when I do see those type of injuries, for instance, we had an athlete that had bone-on-bone knee OA, and that athlete was 21 years old. And so when you see something like that, then you question, like, did you have an injury in your adolescent years? And they said yes. The surgeon had to do, they told me they take a piece of my meniscus out, and then it starts to make you want a little bit more what happened in that time.
All right, I've got a comment here from Dr. Mooney, who's going to be one of our speakers. She's speaking next week. She is talking about how in her county medical system, she has found that a lot of kids with Medicaid and ACL injuries went to the county urgent care multiple times before being referred to the sports medicine clinic, and some were likely playing on an ACL deficient knee for years. She thinks that the system is set up that potentially people maybe never went to their PCP but went to urgent care instead, was told 2 weeks of rest and then follow up, and didn't do that. Is that something that you're seeing in your area as well?
Absolutely. So I'm going to give an anecdote. I'm going to give a example, and then there's actually a study. I can't think of the study right now, but they were looking at ACL injuries in adolescent athletes, and they showed that individuals that were underinsured, whether they had Medicaid, were more likely to present to an urgent care or emergency room as opposed to their primary care or sports medicine physician for their first visit. And then they actually showed that for those individuals who did not present to a sports medicine physician or orthopedist, and presented to the emergency room first, it took them longer to get their MRI, and actually took them longer for them to get to their surgery. From an dental standpoint, there's one athlete that comes to mind. When he was 14 years old, he was running a base, felt the pop, had a large effusion. He presented to emergency care. They told him it was a knee sprain. He went back playing on it, had another injury. I saw him 2 years later, still having recurrent effusions, and he was ACL deficient the entire time. So I absolutely agree with your statement that you made there.
Mm-hmm. All right, I've got a question here from Colleen. It's, how do we actively counter our implicit biases? Are there things that we should be doing as part of the sports medicine team, having meetings and checking in with each other to help keep everyone accountable?
I think the first step is realizing that we have a bias. I think that is the first step. And then once you realize you have a bias, I know I've seen some trainings about implicit bias training. I think at the membership level, whatever various memberships should be doing it, but I also think it should be done at the educational level, and not just within medical education. I think it should be almost at the high school level, because if you don't realize that you have those biases in your adolescent years, you start to develop them, and then they it becomes a part of your, your subconscious. You don't even realize that you're having a bias because it's been ingrained in you for so long. And so I think we have to start definitely at the adolescent and even at the younger kids level, because, my son right now, he's 14 months and, he doesn't have any biases. Someone, and he just wants to wave at him and hook, So at some point that changes. And we got to figure out why, we got to figure out when it's changing so that we can interact at a much earlier level. But at the level that we're all at now, I think definitely in our national conferences, there should always be some form of implicit bias lecture or training so that we're always reassessing what we're doing.
All right. I have a question here about there's speculating. It's Brenda's asking about whether they have looked at the access to care and the healthcare disparities in countries with universal healthcare.
I'm thinking of one study where they looked at ACL injury. I think it was done in Sweden, and I think they did not notice a statistically significant difference with regards to their knee injuries in a universal healthcare system. There might be some other ones I just can't think of off the top of my head right now, but it would address the access. It would address some of the access to care. I know there are some components of universal health care and some not. Some folks that do have issues with is that even though everyone does have insurance, it still takes a while to get to a specialist, and so that could play a role. But to your point, we need to fix what we have going on right now in some fashion.
Cindy has a question, and she's asking, what can those of us at low socioeconomic schools do to improve care or to get more athletic trainers on site? She says that she has 475 athletes and 1 athletic trainer, which makes it hard to provide top care to all the athletes. So where could she start in that push to providing either more care or more coverage?
Great question. So one, in a lot of areas, you might have a safety net hospital. And so if you do have a safety net hospital, trying to partner with them to say that, hey, I do have a lot of athletes which are within a shot of your hospital. I would love to establish a plan to be able to get those athletes in. That's one way. 2, there are various groups that might be available, not that we're just thinking to help reduce disparities, but might be for other things as well. So it might be to reduce disparities in adolescents. Well, we can use that grant to hopefully to pay for a portion of an athletic trainer's salary so that we may not have a full athletic trainer, but at least have another person there part-time. And then when you start to build relationships like Dr. Keeney was referring to earlier, you start to build relationships and then you can start to slow down the burden some. Now, it will not solve the fact that that 1 athletic trainer has 175 athletes.
Mm-hmm.
However, maybe we can take off 20 here and 20 there. And then I think that's the way to start. I think the second thing is that having educational seminars with the coaching staff and also with the parents. Because I think educating those folks to watch out to the signs for some of these injuries will be able to help out that athletic trainer as well. Because if they're seeing a child with a knee that keeps having these effusions, it might trigger them to say, you know what, I just don't think it's a brain time. I think we need to get you in front of something. And so that athletic trainer may not be able to get to that 400th child, but that parent hopefully will be able to see it, and they can be supplied with that knowledge base to know that something is not right.
Yeah, and another thing, just considering this on the county level, at our county we don't have the 2 private schools in our county have athletic trainers, but aside from that, there are not any other schools in our county that have athletic trainers. And so instead of that, the county did take funding and put it towards a secondary claim insurance, which could potentially alleviate some of that difficulty in finding providers to see the athletes with injuries. And now Jessica has a really good comment here. She's talking about the NATA and state associations have the ethnic and diversity committees that could already be addressing issues and have strategies towards addressing those. I'm going to share that. Let's see, here's another comment coming from Sammy. It is really sad to see some high schools still don't have athletic trainers. I came across an athlete a couple of years ago that had post-concussion syndrome because he had never healed properly from his concussion in high school. And he mentioned how they didn't have an athletic trainer and was just listening to what the coaching staff had suggested. I think it would be beneficial for coaches to have training as well.
Absolutely.
Let's see, Alicia is asking, CEU credit-wise, CEU credits are available for all states, for any athletic trainers in any state. Okay, I'm not sure how to pronounce this name, but we have an athletic trainer with the last name of Gardner who asks, I know much of the literature compares healthcare disparities among race with socioeconomic status. Have you found any orthopedic studies that have mentioned bias due to a perception in pain tolerance, similar to that of Black women while giving birth?
So there is actually a study, man, I'm blanking on it right now, that was actually done at the collegiate level, and they gave a written scenario where they use the name of an athlete that might be, let's say, more of a Caucasian name, and they asked the training staff, the athletic training staff, and also the sports medicine physicians to decide this person had ACL injury based on they didn't say based on their name, but they gave them the entire scenario and they gave the athlete's name. Do you think this person or more likely, would need higher level narcotics? And then they gave another written scenario when they used a person more named for more ethnic background, and they just hit it within the same paragraph, and they gave out to those same medical training staffs. They noticed that for the clinical scenario that had the more ethnic name, they are less likely to receive pain meds if they came complaining of pain on their ACL surgery. And so that study is hard, because it's like, okay, well, they're just using a name, but however, phonetically, there's been some other studies that show that there's some bias based on names alone. And so that study did kind of highlight that, showing that, hey, there is likely some implicit bias going on, even at the sports medicine level when it comes to the treatment of athletes.
All right. Karen has a question here. I know Morehouse is involved in their communities. Do they have an athletic clinic with hours outside of the standard 8 to 5 hours?
So currently for the student athletes, just a full disclaimer, so I am not a employee of University of Morehouse Healthcare. However, our head team physician is a part of Morehouse Healthcare. She has her regular student health clinic between those hours. However, for our athletes, we do have injury checks that we typically do 1 day a week. Definitely during football season, where they're either sometimes 2 days a week to take care of the athletes. Some of the other sports, such as basketball and baseball, will have sometimes 1 day per week, or we might do it bi-weekly to come by to make sure we're having injury checks, which are after hours. The athletes are having their injury rest.
Yeah, that's similar. In the fall, we have Saturday morning clinics to make that more accessible. Christine has a question here. Have you heard anything about school districts getting less expensive insurance premiums, both offering a primary insurance and/or secondary policies for the schools themselves? For the insurance policies and associated costs for the school districts that have athletic trainers on site and on staff. So saying the question is about the insurance premiums cost being less or different when the athletic trainers are on site or on staff.
I do not know the answer to that question, but I'm more than willing to try to do a deep dive, but I do not have the answer to that question.
And if someone else does, please feel free to post in the questions. I'm happy to read it off. Okay. Fred has a question about, will the use of telehealth improve access and improve follow-up?
I definitely think that it has a chance. Yes. For instance, I had a patient yesterday, which I did a ultrasound guided procedure on, and the patient didn't show. And so I just called the patient. They told me they were having transportation issues, but I was able to address their issues via phone. In the land of COVID-19, we're starting to use telehealth more, and so I'm actually able to reach some of my patients who actually have difficulty breathing. So to answer your question, I definitely think it would improve access to care. Now, as far as outcomes, well, I can't say that wholeheartedly. I want to say, but on the access end, I would say that it's definitely possible to improve access to care.
Okay, Christine asks, have you heard of any research comparing orthopedic injury rates with ACE or adverse childhood event trauma scores?
I have not seen that, but I can look it up. But I have not seen that one. That's a great question. I have not seen that.
All right. And we have, Karen teaches at the high school level, and she teaches the different biases and barriers at the high school level. And someone is letting us know they are listening to the webinar, riding their enduro bike in the North Carolina mountains. They feel it's a serious problem getting kids access to orthopedic clinics. Okay. All right, good. And a few thank yous here. So let's see, I'm going to go ahead and show my screen here and pop this up so that everyone knows. You're going to receive an email 1 hour after the webinar concludes. I'll move some of these things out of my way, which includes a link to the combined quiz and assessment and evaluation. And so that everyone knows, next week, our next webinar is with Dr. Caitlin Mooney talking about cycling injuries, and that's going to be next Tuesday. Right, well, thank you, Dr. Stafford. Is there any last comments that you would like to share with us before we conclude?
Thank you everyone for tuning in today. Like I said before, I want this presentation to be used as a conversation starter to improve the access to care not only for athletes, but for all individuals who must assess.
Awesome. Well, thank you. And thank you, everyone. Stay safe, stay healthy out there, and we'll see you at the next one.